One of the most frequently asked questions we get is, what is best care and treatment for ARDS in intensive care? I've got the answer to that today. Stay tuned. My name is Patrick Hutzel from intensivecarehotline.com, and this is another quick tip for families in intensive care. So one of the most frequently asked questions we get from our readers and clients is, is my mom, my dad, my family member getting best care and treatment for ARDS in intensive care? ARDS stands for acute respiratory distress syndrome, also known as lung failure. So, and the mortality for ARDS is generally speaking higher compared to other admissions into ICU. So this is a very relevant question, and you obviously need to know and understand what's happening when your loved one is in intensive care with ARDS. So ARDS, or also known as acute respiratory distress syndrome, in layman terms, lung failure, is a severe lung condition that requires intensive care management. Treatment in ICU is focusing on improving oxygenation, supporting organ function, and addressing the underlying causes. Here's an overview of ARDS treatment in ICU. And before I go on in the overview, as much as improving oxygenation is obviously one of the main goals, the issue and major challenge with ARDS is that chest x-rays are often showing a complete whiteout. And what that means is, there's no, the oxygen, the lung tissue is often damaged, right? And the lungs cannot oxygenate, right? And that obviously is life-threatening. So let's look at it in more detail. Number one is mechanical ventilation. So low tidal volume ventilation, also known as LTVV, 4 to 6 millimils per kilo of predicted body weight to reduce ventilator-induced lung injury. So why is that? Especially when the lungs lack compliance and are very resistant to oxygenation. The lower the tidal volume, the higher chances you're overcoming that resistance, and you're improving compliance, and therefore gas exchange, i.e. oxygen going into the body and carbon dioxide coming out of the body, is actually happening and improving. Next, PEEP, positive end expiratory pressure, which keeps the alveoli open, which is where the gas exchange is taking place, and is improving oxygenation. Next, prone positioning. Turning patients onto their stomach can improve oxygenation by redistributing lung perfusion. And also high-frequency oscillatory ventilation, HFOV, sometimes also used in severe cases. And I've worked in intensive care and critical care nursing for 25 years in 3 different countries. I've seen some cases with high-frequency oscillation ventilation. Once again, the approach is to get lower volumes, but at a high speed, and that is also helping. And that is often that is always combined with oxygen therapy, which means FiO2 titration. FiO2 stands for fractionally inspired oxygen, to maintain oxygen saturation between 88 to 95% to avoid oxygen toxicity, but also to avoid desaturation, because desaturation could become lethal and patients could die. And oxygen therapy is also necessary to maintain physiological arterial blood gases that are compatible with life. And as a last resort, ECMO can be used. ECMO stands for extracorporeal membrane oxygenation, which is used in severe refractory ARDS when ventilation fails. So what is ECMO doing? ECMO is basically a bypass machine that oxygenates blood. So how does it work? Blood is being withdrawn from the veins, big veins in the body. They are run through a bypass machine where carbon dioxide is getting removed and oxygen is getting basically put back into the blood, and that's being reinserted into the arteries of the body. Basically, is bypassing the lungs to take over the function of the lungs so that the lungs can actually recover. Next, fluid management. Conservative fluid strategy to prevent pulmonary edema while ensuring adequate organ perfusion. So what that means is most ventilated patients in intensive care should be kept dry. What that means is, the minute you're fluid overloading a patient that's ventilated, the chances of them not being able to ventilate properly is much higher because you've got fluid build up on the lungs, diminishing gas exchange. And now in ARDS, you've already got damaged lungs, right? You don't want to have an extra fluid build up on top of that, because that could make things even worse. Next, medications, sedation and neuromuscular blockade to facilitate ventilation and reduce oxygen demand. So what does that mean? It means that in order to ventilate a patient that's suffocating more or less because the lungs are so severely damaged, right? Patients end up on sedatives such as propofol, midazolam/Versed, or Precedex. They also end up on morphine or fentanyl for pain relief, for pain management, while they're being ventilated with a breathing tube or a tracheostomy. Most cases for ARDS are ventilated with a breathing tube, not a tracheostomy, right? And the breathing tube in the mouth or in the nose can be very uncomfortable, right? So on top of that, neuromuscular blockade, what does that mean? Sometimes in ARDS, or even with other ventilated patients, sedatives such as propofol, midazolam/Versed, and or Precedex are not enough to keep patients sedated, even if you're giving morphine and fentanyl on top of that. They are fighting against the ventilator, right? They feel like they're suffocating. So one way to deal with that is by giving patients a muscle relaxants or a neuromuscular blocker to basically stop all resistance. It's not very nice, and patients need to be even on more sedatives and opiates so that they can't feel that they can't move. But it is effective. It's effective in the moment, but it also takes longer for patients to recover once they've had neuromuscular blockade and high doses of sedatives and high doses of opiates. Next, steroids or corticosteroids is also considered in moderate to severe ARDS to reduce inflammation. Now, most ICUs that I've worked at, we always were giving steroids for ARDS, and I've worked in many ICUs around the world, and I've looked after thousands of critically ill patients and their families, so I can confirm that steroids is a regular treatment option. Next, antibiotics, if a bacterial infection is present or suspected. But the same is applicable, antivirals if a viral infection is present or suspected, and the same is applicable antifungals if a fungal infection is present or suspected. Next, vasopressors or inotropes if needed to support blood pressure. So vasopressors or inotropes should be used to support blood pressure, and assuming blood pressure is low and not compatible with life and not compatible with organ perfusion, right? That's when you need inotropes or vasopressors such as levofed, norepinephrine, noradrenaline, phenylephrine, epinephrine, vasopressin, norepinephrine, dopamine, dopamine, and the list goes on. Milrinone as well. Next, treating the underlying cause, addressing infections such as pneumonia, sepsis, etc. Managing trauma or other conditions contributing or leading to ARDS. And lastly, supportive care, nutritional support via enteral feeding, i.e. nasogastric tube, some very rare cases, PEG tubes, deep vein thrombosis, DVT, and stress ulcer prophylaxis. Deep vein thrombosis prophylaxis is usually done with calf compressors, TED stockings, or medications such as Clexane or heparin. Stress ulcer prophylaxis is usually done with enteral feeding, and it's usually done with giving a proton pump inhibitor such as esomeprazole, omeprazole, ranitidine, or Zantac to prevent stress ulcers. Next, physical therapy to prevent muscle wasting whenever possible. Again, that goes without saying, because when someone is in an induced coma for ARDS, they need to keep moving, because otherwise, they decondition extremely fast, and it's also DVT prophylaxis, the movement. So that definitely needs to happen as well. And like I said, I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 here at intensivcarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivcarehotline.com. And you can verify it on our intensivcarehotline.com podcast section, where we have done client interviews, and you can find our podcast again at intensivcarehotline.com. And because our advice is absolutely life-changing. It's absolutely life-changing. And you can join a growing number of clients and members that we have helped over the years to improve their lives instantly and to save their loved ones' lives, or at least to get a better outcome for their loved ones. And that's why I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. I also talk to doctors and nurses directly, and I ask all the questions to the doctors and nurses that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. And I hold them accountable, and you will see how the dynamics will change in your favor very quickly. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivcarehotline.com, if you click on the membership link, or if you go to intensivcaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email. And we answer all questions intensive care related. You also have access to 21 ebooks and 21 videos that I've personally written and recorded, making sure you make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. And all of that you get at intensivcarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivcarehotline.com with your questions. And if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Like, comment, subscribe, click the notification bell, share the video with your friends and families. I also do a weekly YouTube live where I answer your questions live on a show, and you will get notification for the YouTube live if you're a subscriber to my YouTube channel, or if you're a subscriber to my intensivcarehotline.com email newsletter. Thank you so much for watching. This is Patrick Hutzel from intensivcarehotline.com, and I will talk to you in a few days. Take care for now.